So we are discussing about the symptom. So patient will complain you. Okay, dyspnea where there I'm having a problem with the or difficulty with the breathlessness, difficulty in breathing. So ultimately, when I go for the mild amount of walking or some amount of work, I'll be having a breathlessness. I'm having a cough, but it is dry, which is non-productive. Huh? Or so many different symptom which is related to connective tissue disease, huh? Which can also happen in the case of an interstitial lung disease. If you see X-ray, you will see thickening of the bronchiole, huh? Thickening, or we can call it a calcification or opacity, radio opacity. You may find in an X-ray in the lower lobes. Lung function, pulmonary function, if you go for, there will be a decrease in the vital capacity, decrease in the FEV1. So ultimately, you'll be having an increase in the FEV1 by FEC ratio. You can see the clear-cut restrictive picture. If you can see the HRCT, again radio opacity or honeycombness, you can see in the lower zones. Okay, so these are the flow chart. You see, first is many more idiopathic interstitial lung disease with the non-cause, maybe drugs or collagen vascular disease or anything. Then they will be having a granulomatous interstitial lung disease like sarcoidosis or other ILDs. Right? In that, you'll be having a major portion is idiopathic interstitial pneumonia. In that, again, you'll be having IPF. Once IPF is confirmed, when there is a no cause, when you'll be having a other than IPF, then you can see, okay, there will be a pneumonitis. What are the causes of pneumonia? It may be uh, non-specific pneumonia or cryptorchogenic or acute interstitial pneumonia or lymphocytic or respiratory bronchiolitis or discomative. So depends on the pathology, we can go for the classification. It depends on the some causative factor. When there is no causative factor, you can say it is idiopathic pulmonary fibrosis. Yes. Again, non-cause, unknown cause. Then some alveolar proteinosis, granulomatosis. Ultimately, because of the protein-rich fluid will happen in and around the alveolar capillary network. When it is bound, when it is not working properly, it is adherent to each other, there it loses its capacity to expand. Ultimately, our expansion capacity will be reduced, compliance reduced. Again, we have seen the major and minor criteria. Yeah. So what you need to take, you need to note down in your normal demographic data age, which is more than 50, or if it is sarcoidosis, then 20 to 50. This according to age also you need to note down. Gender, generally male will be affected. Smoking history is present or not. Duration, since how many. Coughing will be there, dry cough will be there, and at least 3-month history will be there, which is progressive. The fever, weight loss, night sweats, loss of appetite will be gradually and progressive. Yes. So we need to rule out the connective tissue disease, substance abuse, maybe HIV infection, occupational and environmental diseases, any medicational, sexual orientation, family history, various things we need to focus in our assessment. So generally, this 4 histopathogenically distinct subgroups of idiopathic interstitial pneumonia, as we had seen here. Idiopathic interstitial pneumonia. So these are the things will be there: non-specific interstitial pneumonia, acute bacterial pneumonia, respiratory bronchiolitis, discomative interstitial pneumonia, lymphocytic pneumonia, and cryptogenic organizing pneumonia. So here they are telling the same: interstitial pneumonia, which is usual one, discomative interstitial pneumonia, acute interstitial pneumonia, and non-specific interstitial pneumonia, NSIP. Yes. Okay. I'm not going into the detail of that. See, many classification of interstitial pneumonia in the children aged between 0 to 2. So this interstitial lung disease can happen to the younger age, infantile age, pediatric age also, before the age of 2. So many more pathologies are present related to different genes related also. Yes. So already we have seen this all. Fine. So what are the evaluation you may see? Yeah. So the symptom which is rapid onset and worsening very fast. Just 3 months before, the patient has been diagnosed with the such disease, and after the 3 months, it is very critical. The patient may have a smoking history or any occupational history, drug exposure. Person may complain about the hemoptysis, maybe pleurisy. See, because any infection or any inflammation will transfer into the pleural cavity. You may see the wheezing because of the uh, narrow passage. You can see another systemic disease also. Yes, renal disease, arthritis, myalgia in case of a connective tissue disease. So these are the clues can be received from various different cases, like renal disease, ERD, Zika syndrome, skin, some symptom you can see, arthralgia, myalgia, synovitis, muscle weakness, neuropathy, or maybe chest pain. But ultimately, these are the symptom of connective tissue diseases. So you need to rule out whether the person is having any connective tissue diseases or uh, occupational lung disease, or there is unknown cause. We can call as a IPF. So we need to first rule out, and then we can go for the treatment. So in the ILD, the chief complaint will be dyspnea. Then you'll be having a cough, maybe hemoptysis. Then if you see in the examination, chest radiographs will be seeing infiltrates, decreased pulmonary function, and you'll be seeing a restrictive tendency, gaseous exchange will be decreased. Yes, if you see the X-ray, mediastinal adenopathy can be seen. HRCT, bibasilar mean both the base level, both the lower lobes, you can see radio opacity, reticulonodular opacity, or honeycombness, you can see like a bronchiectasis. So bronchiectasis, corona, pneumonia, this IPF, all look same with the some difference. Yes. So how to categorize this? What are the diagnostic tool in suspecting the interstitial lung disease? So when the age is more than 50, you can diagnose IPF, cryptorchidinic organizing pneumonia. If the patient age is 20 to 40 years, you may suspect sarcoidosis, connective tissue disease, or associated ILD, sarcoidosis, or lymphangionomatosis, pulmonary Langerhans cell histocytosis. These are the common symptoms. Common disease happening in the 20 to 40 years of age. But usually, whatever you will see, restrictive cases will be more than 50 years of age. Yes, male occupation history will be more. In the female, there will be a connective tissue, especially Raynaud's disease, rheumatic fever, and this all will be more in the females. Yeah. Family history, connective tissue disease or diagnosis or symptom may have. Occupational exposure of the drug, smoking, environmental exposure, or occupation, like asbestos, silica, may be there. You may see the physical examination. You may see the physical examination, crackles or wheeze, clubbing because of the chronic hypoxemia, clubbing may be there. Or you can see signs of right heart failure, that is cor pulmonale, or some extrapulmonary sign you can see, or what the laboratory on investigation you can see: CBC, complete blood count, chemistry, liver function test, rheumatic serology like ANA. You can go for that. You can rule out the Reynolds disease with some test. RA factor you can search. Pulmonary function test in examination like spirometry, lung volume, diffusion capacity test. DLCO we had discussed about lot in the pulmonary function test. 6-minute walk test, go for, they will show you the current capacity, exercise capacity of that person. Arterial blood gas analysis will show you the not SpO2, PaO2. Are you able to see my screen, student? Yes?
No, sir.
No, sir.
You're not able to see my screen? Now?
No, sir.
No, sir.
Okay. Okay. So I was explaining about demographic detail on observation, palpation, percussion. So you can write about auscultation, bibasilar crackles, early inspiratory crackles. Palpation, what palpation? Expansion will not be there. Very less expansion will be. Percussion, what you can feel in the percussion? It is pneumonia. So there will be a dull percussion note in the lower at the base. Examination, as here they have shown, clubbing, crackles, wheeze, signs of cor pulmonale. What are the signs of cor pulmonale? Increased jugular venous pressure and all. These are the pulmonary function testing, which can include the 6-minute walk test, arterial blood gas analysis, all. Then on investigation, X-ray, CT, bronchoscopy, then you may have a biopsy and all. So ultimately, we need to find out which are the cause. We need to find out what is the cause. Okay, so that may be occupational lung disease, that may be idiopathic pulmonary fibrosis, or it may be idiopathic pulmonary pneumonia, or it may have some cause. So these are the dust causing pneumonia, or some inorganic or organic, and maybe metals or maybe fungi. These all are causing different areas. So if there will be a fibrous dust or maybe asbestosis, they will lodge into the lower zone. And predominant reticular opacity, honeycombness, you can see, and sometimes pleural diseases also. When you'll be having a crystalline or silica, it can affect the upper zone predominantly. And nodular disease, which is progressive, massive fibrosis, and hilum, which is nearer to the this origin of bronchus, where the bronchus insert into the lungs, there will be a hilar opacity. Yes, because of this hilar opacity, and there will be a inflammation of the lymph nodes. That is called as adenopathy. There will be adenopathy. Yes. Then coal dust. Coal dust will be exposed. They will be having exposure to the upper zone predominantly. Again, it is nodular disease, progressive, massive fibrosis, you may see. So fibrous dust, asbestosis affects lower zone. Inorganic core, they will affect the upper zone. Metal like beryllium, like nuclear weapons, electronics, aerospace, ceramic, machine or dental prosthesis, alloy machine, where this beryllium, they will be having a chronic exposure. Ultimately, they will affect the middle and upper zones. Yes, fine. So we'll not go for this. So you need to go for CBC, where you will go, you will get the anemia, or where there will be a leukocytosis, neutrophil neutrophilia or eosinophilia or thrombocytopenia may be there. You can go for calcium checking, creatinine, liver function test, urine, muscle enzymes, ACE, angiotensin converting enzyme, lymphocyte proliferation, and serum antibodies. So this all the investigation we are going for ultimately to rule out various different diagnoses in the IPF. Ultimately, interstitial fibrosis, interstitial lung disease, or restrictive lung disease contains many diseases. And to rule out which are the causative factor, we need to go to about this test. You can go for chest X-ray and HRCT, each one having some particular pattern which is related to particular diagnosis. Like hilar lymphadenopathy will happen in sarcoidosis or malignancy. Septal thickening will happen in a chronic heart failure, malignancy, and infections. Yes, or pulmonary veno-occlusive diseases. Lower lung zone IPF, asbestosis, or CTD, connective tissue diseases. Mid and upper lung zone sarcoidosis, silicosis, acute hyperneumonaitis. See, these are the commonest ones. This may appear something wrong. It is okay. Yeah. So you can go for the X-ray and CT scan for confirmation about the pulmonary fibrosis. Yes. Ultimately, how to rule out. So first, if you see the patient may be having ILD, suspected or possible, you go for the history checking, physical examination, lab testing, and thoracic imaging. Okay, you confirm, okay, the person may be having the 50% chances are there. Now we need to confirm about some particular type. Okay, the person need to go for bronchoscopy. Okay, the person will go for bronchoscopy or bronchoalveolar lavage. With this inside, they will insert this scopy and they will take a sample. Yes, the sample analysis will see bronchoalveolar lavage fluid will be going for analysis, visual inspection, cell count, microbiology testing, and all, or maybe malignancy is happening or not. And then endoscopic lung biopsy. Okay, what is the happening? Is there any cancer or not? Again, after that, will patient, okay, it is not diagnostic at all. The patient is having not this anything related to that, or is there any particular diagnosis is there? If there is no need to go for the bronchoscopy, then they will go for the lung biopsy, and ultimately they will go for the confirmed diagnosis. If there is no confirmed diagnosis in the bronchoscopy and bronchoalveolar lavage or biopsy, you can confirm that the patient is having a idiopathic pulmonary fibrosis. Yeah. Okay. So you may look pulmonary fibrosis like this. You see calcified opacity, honeycombness. Honeycomb means મધમાખીના માળા જેવું તમને લાગે. Honeycomb appearance. You see, this is the heart region. Hilar mediastinum lymphadenopathy. You see this hypersensitivity pneumonitis. Fine. So these are the common thing we will go for this. Okay. So with this we will finish. Okay, next class again we'll go for the remaining thing, and next class we'll go for the finishing of this restrictive lung diseases, right?